So our last presentation, but definitely not least, I'd like to introduce Dr. Henk-André Kroon, who is the head of translational medicine responsible for early development and biomarkers at Annexon Biosciences. So Dr. Kroon will introduce us to some results from their recent phase 2 study and a whiff of what might come next.
A whiff. So thank you, Chairman, for the opportunity to share the results with you and the audience here from our phase 2 study with the anti-C1q therapy ANX005 in patients with HD. I work for Annexon Biosciences, and we develop therapies for complement-mediated disease in the body, brain, and eye, but we will focus on the brain today. I will talk a little bit about the future, so this is relevant. Our lead compound is ANX005. It targets C1q, that's the initiator molecule of the classical complement pathway. Now, we know from the work of our founder, the late Bernhard, that C1q is involved in early brain development, in pruning of excess and weak synapses so that you can develop healthy and well-functioning neuronal networks. And that's a very benign process, very well regulated, and it is active for a short duration. Later in life, that very same process can cause chronic neuroinflammation in the brain, as well as damage and removal of functioning synapses, and that, of course, will lead to loss of function and disability. And we call this the Bernhard hypothesis. So this particular process is actually very common, we believe, in neurodegenerative diseases. What is important, it's triggered somehow. And that could be oxidative stress, light damage, it could be an abnormal protein like A-beta, or in the case of Huntington, mutant Huntingtons. What actually happens is that the surface membrane of the synapse becomes abnormal, and C1q, which is a pattern recognition molecule, now understands that this is abnormal tissue. It binds to the synapses and then activates complement. Now, complement is a classical complement, and the complement pathway is an amplification pathway, and it enzymatically cleaves the primary components in complement, that's factor C2, 3, 4, and 5, in activation products, which are labeled A, and complement markers that bind to tissue and are labeled B. So in the case of Huntington's disease, C1q binds to the synapse. The surface is then coated around the binding site with activated complement components. C4b and C3b are eat-me signals for the macrophages in the brain, and the C5b9 is the lytic complex that can actually punch holes in the synaptic surface. So this leads to functional compromise. In addition, the activation factors, and particularly C3a and C5a, recruit and activate microglial cells, and of course that drives further neuroinflammation on the synapse. Eventually, these macrophages in the brain damage and phagocytose these synapses, and that's the way they are being removed, and of course that leads to functional decline. With this ongoing loss of synapse, you lose trophic support for the neurons, and that leads to compounded neuronal stress, and eventually you have extensive neuronal damage and neuronal loss, which you can characterize by the release of NFL. Now, Bernhard actually postulated that in low-functioning synapses, C1q inhibition could actually lead to restoration of function very early in the treatment. We have now also postulated that perhaps in patients with significant neuronal damage, and where you can identify release of NFL, it may take much longer to show an improvement with effective complement inhibition. Now, in all the diseases that we target with anti-C1q therapy, we want to understand that the level of complement activation correlates with disease activity or progression. And we looked at the activation product of C4, the first component in the classical complement pathway in the CSF, in a collaboration with Ed Wild about 3 years ago, prior to the start of this study. And what you can see here, that C4a levels in the CSF are elevated in HD, and they continue to increase with progression of disease. And in addition, these the elevated levels of complement activation correlate very well with various functional measures, including motor and cognitive function. Now, what is important that in that you see here in the early manifest patients, about 50% of those have C4a levels in the CSF that are above normal. And that's an interesting population we're going to talk about. Recently, we discovered that you can actually enhance the signal of C4a in the CSF by looking at the C4a-C4 ratio. It's more sensitive, and it also allows you to normalize for variation, the natural variation in C4. And importantly, and please remember this, in most of the diseases that we target, we actually select patients with high levels of complement activation, meaning they have a high C4a-C4 ratio, because we believe that those are patients that are most likely to respond to our therapy. So that's it about complement. So this is the phase 2 trial that we conducted. It's a signal finding study, open label, with a monoclonal antibody ANX005. Patients were in screening for about 8 weeks, and they were vaccinated against encapsulated organisms. And then they received ANX005 intravenously. There was 2 doses within a week of an induction, and then they received ANX005 every 2 weeks, and the last dose was given at 22 weeks. The on-treatment period was defined as 24 weeks, and then they were followed up during off-treatment for 12 weeks for a total duration of 36. We selected patients with early HD, and the endpoints are very consistent with a trial with early clinical development, safety and tolerability, PK of ANX005, and it was very biomarker heavy when we looked for target engagement, markers of complement activation, neuronal damage, both in blood and in the CSF. And of course, we were very interested in initial efficacy. We enrolled 28 patients were treated with at least a single dose of ANX005. These were included in the safety analysis. 23 patients completed the full 24 weeks, and those were used in the efficacy analysis. And in order to better interpret the NFL data and the efficacy data, we did include the natural history data from Track HD, and that's why you see the baseline demographic characteristics of that study listed here. And as is clear, each of these populations are very comparable. So here's the PK, and you can see here that ANX005 demonstrates complete and very durable complement inhibition, both in blood and the CSF. Blood is red, CSF is blue, the solid line is ANX005 levels, and the dashed line is free C1q. And as you can see, in the presence of ANX005, so after the first dose, free C1q is undetectable, meaning there's complete complement inhibition, and when you stop treatment, these ANX005 levels decline, and C1q activity returns to normal. This is mirrored in the CSF, where you can see this, the same off-on scenario occurring. We noticed that target engagement actually lasts pretty long after stopping of treatment, and so we may be able to look for a more convenient dosing schedule. We reduced downstream complement activation, and we looked at activation factor C3a, which was reduced from baseline on and off treatment. And also, there was a decline in C3, and that's actually rather important because we know in neuroinflammation, C3 is elevated, produced by activated microglial cells as well as neurotoxic astrocytes. And we have further biomarker data that actually support this finding on the effect of neuroinflammation. We looked at NFL that pretty much trailed the natural progression based on the various natural history data. And if you use NFL as a safety biomarker, it's clear that there is no safety signal here. In terms of efficacy, and you're looking at the point estimates over time, there was stabilization of clinical disease progression during 9 months, but of course the confidence intervals are rather wide. And then we went back to our initial hypothesis that stated that patients with high levels of complement activation are more likely to respond to therapy. So we defined high levels of complement activation as patients having being in the top 50% C4a, C4 ratio. And so that's about 50%. We use the median, and so you have high level of complement activation in, those are patients in the green. There are 12 of them, and low levels of complement activation at baseline, the blue line, 11 patients. And what you see, there's an early improvement actually in function, which is like the hypothesis of Barris, that is maintained during treatment and off treatment. And patients with low baseline, a low C4a, C4 ratio at baseline, pretty much follow the expected decline. And this is true for both the composite UHDRS, the TFC, and the individual domains, which I cannot show because of time limits. I do want to show you the actual individual patient data, and it basically shows that about twice as many patients with elevated baseline complement at baseline improved or were stable relative to baseline compared to those patients with lower levels of complement activation. And this is true at week 24 as well as 36. In terms of safety, we saw infusion-related reactions. That is a known feature of ANX005. We've seen that in other studies too. There were none after the second dose, no deaths, no serious infections were observed. You do inhibit innate immunity. There were discontinuations unrelated to drug, but there were 3 that were potentially related to drug and all improved and resolved after drug cessation. Those are independent events, an idiopathic pneumonitis, a lupus-like syndrome, as well as mild hemolytic anemia. And all these cases had one thing in common: they had elevated ANA titers at baseline, and no patients with normal ANA titers showed any serious adverse events. So in our future trials, we will exclude patients with high ANA titers to mitigate against the risk of any of those things happening. So in summary, these are very promising results. And we certainly feel that this warrants continued advancement of this therapy in Huntington's disease. We showed you full C1q target engagement and complement inhibition both in blood and in the CSF. We stabilized the disease progression. There was a differentiated treatment based on MOA and complement levels of complement activation. And there were improvements in important biomarkers of neuroinflammation. And generally speaking, in this severe disease for which there's no treatment, there's a favorable benefit-risk profile at this point in time, and we will work on enhanced safety management approach. So I would have liked to be here and do something similar as previously done and tell you exactly what we're going to do and where and when, but we are not there yet. What we will do and what we have committed to is that we need to confirm these promising data in a proper adequate and well-controlled clinical trial, and we will start the trial in 2023. Now, currently, we are engaging with you, patients, experts, and of course, regulatory stakeholders, and we will complete that by the end of this year. Now, the forward-looking statement is really this: it could be a trial with 250 patients with early Huntington's disease. We could enrich for patients with elevated complement activity at baseline, because those patients seem to be responding early and very well. We will probably treat patients for a year or longer, and we'll use the same ANX005 dose because it's well characterized now in terms of safety and efficacy in this phase 2 trial. And endpoints, these are the usual suspects, of course. There are other things that we can do and we will consider, and we need your help with that, and we will consult with you and all the stakeholders in the room to design a really proper and well-informed trial. So lastly, I want to thank you all, patients, families, the sites, the people that we work with in general, that are all committed to finding novel treatments for the treatment of HD. Thank you for gathering all this knowledge and providing insight in this disease, and thank you for your attention.
Thank you very much indeed for this outline. We have time for one question. One question. Maybe a question for me. Could you comment a little bit on your choice of endpoints? Obviously, you want relevant endpoints. Total functional capacity, composite UHDRS. how does that square with your preference to an early population of AHD?
That's a very good question. So, of course, what we find, because the composite UHDRS covers more signs and symptoms than the TFC, it is more sensitive to change. And now, we have to take into account that regulators have their own preference as a primary endpoint. What it essentially means is that you will be able to see an early improvement using the composite score. You may even use that in terms of if you want to design a more adaptive trial. But what it also means is that if you have to power for efficacy, you will have to do that on the least sensitive measure, which is TFC. And unfortunately, that is reality.
All right. So,
thank you.
Thank you very much indeed, Henk.